Okay, this is the start of the abdominal exam. I've already washed my hands. I'm going to introduce myself to the patient. My name is Shana Mitchell. I'll be your nurse practitioner for this evening for your abdominal examination. So right now we have the patient sitting on the chair, but if we did have the patient inside of like our office, he would be lying slightly at a 30 to 40 degree angle. So that way we could fully inspect the abdomen area. But right now, as far as the abdominal inspection, go ahead and hold your arms to the side. I'm going to look at the patient's abdomen before I auscultate or percuss anything or palpate anything. The patient's abdomen is rounded, does not feel distended. Slightly protuberant, but it's not in a concave contour, or it's also not flat. I'm not going to raise the patient's clothing up to respect the patient's privacy, but if the patient's clothing were raised up, if he had a gown on, we'd be looking for any type of scarring or striae or any rashes, lesions, or any dilated veins, specifically near the abdominal aortic area. We would also be looking for any bulges in the abdomen area, and for any signs of inflammation. As far as checking peristalsis, I'm going to ask the patient, when was your last bowel movement?
This morning.
Okay. Any blood noted in the stool or anything?
No.
Okay. How often are you having bowel movements?
Morning and evening.
Okay. So we do know that the patient is having healthy bowel movement. That lets us know his abdomen is promoting good peristalsis. The patient, again, I'm not going to raise his clothing up, but for the sake of with the normal limit findings, we're going to know that the patient doesn't have any aortic pulsations anywhere felt on his abdominal area. So now I'm going to auscultate the abdominal area with my stethoscope. And basically what I'm looking for, I'm going to listen in all 4 quadrants for the frequency or character near the midclavicular line, and any pausing in between locations. I'm also going to be listening to bruits over the aorta, renal, iliac, and femoral arteries. Basically, I'm going to be listening to that area near the aorta, just inferior to a point halfway between the xiphoid process and the umbilicus. Renal arteries are no more than 1 inch laterally from the L2, and then the aorta divides into iliac arteries just below the umbilicus, so I'll be looking at each lateral side. I'm also going to be listening for any venous hums or friction rubs, which I'll be listening to over the liver, and I'll also be listening to over the spleen. Okay, so the patient is noted to have good hypoactive and audible bowel sounds in each quadrant. I didn't hear any venous hums or any friction rubs. Next association category, I'm going to percuss. What I'm going to do is use my middle finger and hyperextended at the distal interphalangeal joint, and I'm going to just press on the skin surface with my middle finger, and then I'm going to use my other hand to strike at that point in a brisk fashion. And so basically I'm using this to assess for tympany and dullness in all the 9 areas, to try to distinguish between dullness over the liver and tympany over the splenic flexure. I'm also going to be measuring the span of the liver dullness right at the midclavicular line. Is usually where the dullness will be heard, and then percuss from the level of the umbilicus upward until the dullness is heard, and then measure the span of the dullness in that area as well. I'm also going to be percussing for any splenomegaly, any signs of splenic disruption, assessing the anterior axillary line at the lower interspace, and then ask a deep patient to take a breath while I am percussing. Okay. Next, I'm going to palpate the patient's abdomen. Again, if the patient was in a 30 to 40 degree angle and he was on a flatter surface, he would have his knees bent, his head would be supported, and his arms would be at his side. So I'm just going to palpate for any rebound tenderness, any guarding or superficial masses. And we're going to use our hand for palpation in a horizontal plane, and slide the hand or barely lift the hand to the next location, which I want to palpate slowly, just because if the patient did have some rebound tenderness, I don't want to further exacerbate any areas that the patient reported that there were painful findings. Also want to assess for peritoneal inflammation, and press down slowly in areas of tenderness and then quickly release. Any pain here?
No.
Take a deep breath in. Pain here?
No.
Here?
No.
Pain here?
No.
Here?
No.
All right, lastly, we're going to assess for the costovertebral angle, or CV8 tenderness. Basically, we would use our finger to percuss and make a firm strike against the hand that is laying over the costovertebral angle. And then for ascites, when you're looking for ascites, we're going to test for any shifting or dullness or fluid wave by percussing outward. And with that, we will repeat the steps that I just discussed if the patient were lying on the side. If a patient does not have any ascites, the tympany and dullness will stay constant. And then we would also ask the patient to press the edges of his hands down the midline. And we would tap one side of the abdomen, feeling for the wave to hit the opposite hand on the opposite side. Lastly, the appendicitis, we would look for the Rosing sign. So our right side pain and left sided pressure, or psoriasis sign, which is pain during resisted right hip flexion or passive right hip extension. Again, these would be done if the patient were in the actual office and were lying at the 30 to 40 degree angle. We would assess for obturator sign, which would be pain with right hip flexion and internal rotation, and then we would ask the patient to cough. Another thing with some techniques we would assess during cholecystitis, we would look for the Murphy sign by palpating the liver edge and then asking the patient to take a deep breath and watch for any sharp pain that stops inspiration. Again, this is the end of the abdominal exam. Thank you.